Hi, I'm Andrew Yen, Chief of Endoscopy and Associate Chief of Gastroenterology for the VA Northern California Healthcare System, based out of the Sacramento VA. And on behalf of my co-authors, we would like to thank GIE for the opportunity to discuss our manuscript, Underwater versus Conventional Endoscopic Resection of Non-Diminutive, Nonpedunculated Colorectal Lesions, a prospective randomized controlled trial. Now, conventional endoscopic polypectomy of premalignant colorectal lesions is well established and traditionally performed with the colon fully distended with gas. Now, it's generally accepted as an effective method for polypectomy, and it's been used in practice for decades, but it does have limitations. Now, as endoscopists, we generally feel very proficient with conventional techniques, but it's humbling to note that the rate of incomplete polyp resection reported in prior studies for lesions larger than 5 millimeters in size range anywhere from 2 to all the way up to 30%. And this range does include small and intermediate sized lesions that make up the vast majority of polyps that we encounter in routine practice and that we generally consider relatively easy to remove. But even these lesions are not completely resected in about 10% of cases, and that's from reports such as the CARE study. An incomplete resection of polyps obviously adversely impacts the efficacy of colonoscopy and contributes anywhere from 10 to up to 30% of post-colonoscopy colorectal cancers. So we need to acknowledge that this is an area in need of improvement, and therefore identifying safe, efficient, easily learned, and inexpensive techniques to address the current limitations of conventional polypectomy are important to explore. So an emerging method of polypectomy, initially described by Dr. Binmoller and his colleagues at California Pacific Medical Center for removal of large colorectal lesions, is underwater polypectomy. Our group also described this underwater approach in removing initially a polyp in a spastic segment of colon that couldn't be adequately distended with gas. And then subsequent reports applying underwater methods for removal of small and intermediate-sized lesions by our groups and others followed. And all of these suggested that underwater resection was a potentially safe and effective technique that required no additional equipment or accessories to adopt and perform. For underwater techniques, gas is completely suctioned from the segment of bowel where the lesion is located, and water is infused to partially distend the lumen for visualization. It's also important to perform water exchange thoroughly prior to polypectomy to optimize visualization and to avoid over-distension of the colon with water. Eliminating any air pockets is also very important, as an air-water interface may actually also interfere with visualization and can make the resection more challenging. Air exclusion and water filling allow you to operate in a partially distended colon with less wall tension. The advantages of using water that help in this way include providing a natural magnification effect when viewing objects completely submerged, the smaller footprint and more polypoid configuration lesions tend to assume in a non-distended lumen, and the buoyancy of lesions floating in water and away from the deeper structures of the colon wall, which allows safe resection without submucosal injection. Only one previous prospective comparative study on intermediate-sized lesions, 10 to 20 millimeters in size, in a Japanese referral population has been published. Now, these patients were hospitalized as part of routine practice for their procedures, so we performed this randomized controlled trial to explore the technique of underwater resection for non-diminutive lesions, those larger than 5 millimeters in size, that were encountered in routine outpatient practice. Now, we did exclude pedunculated lesions from this study, as those lesions tend to be easier to completely resect. So for small lesions, 6 to 9 millimeters in size in this study, cold stare techniques were compared in a gas versus water-filled colon. And for large lesions, those 10 millimeters in size or larger, conventional inject, lift, and hot snare, also known as traditional EMR, in a gas-distended colon was compared with underwater hot snare without submucosal injection. And we hypothesized that with underwater resection, this would significantly reduce the incomplete resection rates compared to conventional resection techniques across this broad range of polyp sizes encountered in routine outpatient practice. And over a 2-year period, we removed 462 polyps from 255 patients. And there was no difference in incomplete resection rates and across polyp sizes in this particular study, as both techniques resulted in low incomplete resection rates, as well as infrequent adverse events. We did demonstrate, however, that underwater resection was performed significantly faster for lesions 10 millimeters in size or larger compared to traditional EMR. Time savings between 2 to 3 minutes per lesion on average were observed. And intuitively, this makes sense since you're avoiding the additional steps of injecting, lifting the lesion, exchanging the needle out for the snare, and then resecting. And for larger or giant lesions, sometimes these steps need to be repeated multiple times. And for this particular study, the time savings doesn't even include the time needed to prepare the injectate solution, such as mixing the contrast agent with the solution and then priming the needle, which in real-world practice sometimes can add significant time. So in addition to time savings, underwater polypectomy may also have impacts on costs. So if you're able to avoid the need for the injection needle or injectate solution, which can be costly if you're using a contrast agent such as methylene blue or indigo carmine, or even one of the newer proprietary agents used for traditional EMR that's out on the market today. And as noted previously, underwater polypectomy is relatively easy to learn, and it can be integrated into an endoscopist's skill set with a little bit of education and practice. So we usually recommend starting with removal of smaller lesions underwater first, and then as you become more comfortable with the approach, moving on towards larger and larger lesions. And as with most techniques, once you become familiar with the approach, you will also become more efficient. So our study does have some limitations, and I was the only endoscopist that performed polypectomy in this trial, which may affect generalizability. But the findings suggest that this technique can be safe and effective, and it warrants additional evaluation in larger follow-up studies, but it does deserve consideration as an alternative approach with potential benefits for removing nondiminutive, nonpedunculated lesions in routine practice. Thank you for listening.